Okay, it's my pleasure to introduce Dr. Kelvin Ung. He is a stroke physician that trained in general internal medicine, clinical pharmacology, and stroke medicine in London and Nottingham in the United Kingdom. He completed his stroke fellowship at McMaster University before joining the faculty. He was a National Institute of Health and Clinical Excellence Scholar in the United Kingdom and was involved in technology appraisals for gabigatran prior to its introduction for Wales and England and Wales. His academic interest in therapeutics is focused on the use of novel drugs and treatments for patients with stroke and other chronic disease states. Apart from being a stroke and general internal medicine specialist at the Hamilton General Hospital, he's a keen driver for integrating and aligning clinical research with best clinical practice and is a current recipient of a Castor grant for disseminating clinical research into our district stroke centers. And with that, I'll turn it over to Dr. Ung.
Thank you very much, Tina, for the kind introduction and also for the invite to give this inaugural webinar on post-stroke complications. I recognize some names on the list. I have given a variation of this talk in our stroke rounds in the past, but I'm always look forward to presenting this to a new audience and the input and the questions from the group. I have no conflicts of interest to declare for this talk. I will stop at the end of every objective to ask questions. Please feel free to submit them. The more interaction we get, the better, especially in this inaugural talk, as I feel my way for how much information people will be receptive to in the audience. So as a general overview, I thought I'd start with an introduction stating something facts that may be obvious to this group. So strokes are common. It's not a niche condition, unlike some other neurological conditions. It's the #1 cause of disability in Canada, #2 cause of death. It's a very common condition, common in the elderly, and Canada is an aging population. So this is becoming more prevalent, as you will see in the data I'll show. Some headline figures that you see from our frequent talks: 1 stroke every 30 minutes. In Ontario, 1 every 10 in Canada. It's mostly a morbid disease causing disability, but it is associated with death and mortality, especially our worst kind of strokes, the total anterior circulation strokes. The historical trends suggest that stroke as a contributor to mortality is dropping as time has progressed, and a large part of this is attributed to the fact that stroke incidence rates are dropping. With the advent of new ways of delivering stroke care, stroke units, the new therapeutic interventions that we have, and some of them are incredibly powerful, stroke mortality is improving. So in combination with the fact that the patients are getting older and patients are surviving longer with a diagnosis of stroke, while incidence rates per capita is dropping, stroke prevalence is increasing. So we're seeing more and more patients who've had a previous history of strokes. Drivers for this trends are the fact that significant ones are the management of hypertension in the 70s and 80s, big drop in stroke incidence rate per capita population. We diagnose more strokes nowadays with the increasing use of CTs and MRIs. We do CT scans of heads nowadays very quickly and much more frequently than we ever used to. Stroke units that came in the last 20 years and an advancement of advanced stroke therapeutics like thrombolysis and particularly mechanical thrombectomy, EVT, has really changed the prognosis for patients with the worst kind of strokes, the most disabling and the most mortal, the strokes that are most likely to kill patients. I remember 20 years ago when I started stroke training, a significant proportion of our patients in stroke units will be waiting long-term care because they've been so disabled. Our stroke units now, with the advent of EVT, the proportion of patients who are severely disabled are not too dissimilar from some of the medical wards. Our secondary prevention medicines are changing as well, and there are some major developments there that some of you will be familiar with, but I will touch on. Now, why are stroke complications important? Patients are getting older. They are increasingly the patients that are getting more and more strokes, and we live in a society where there are more conditions that can be treated and are now considered chronic. We are more sedentary. Diabetes, hypertension is much more common than it ever used to, both because of our lifestyle, but also because patients are getting older, and so they're developing these conditions which are related to age. As people get older, AFib is also a lot more common, and hence the risk with strokes. The combination of diabetes and mellitus, diabetes and hypertension in our patients is thought to increase the risk of strokes 4 to 5 times more, adjusted for every other risk factor. So the combination is a really bad combination. You compare that with AFib by itself, increases the risk of strokes 5 times, also adjusted for all other risk factors. So these are probably some of the most powerful risk factors that we encounter. Post-stroke complications are common, they are not uncommon. Depending on how you censure the data in prospective or retrospective databases, direct ascertainment or passive ascertainment, the majority of patients will have some stroke complications. And this probably reflects those of you who take care of stroke patients as a practice. Looking in Ontario data, the most common preventable complications are things like DVTs, pulmonary embolized falls, infections, and skin ulcers. Patients who do get these complications are multiple times more likely to die from them than patients who've had strokes without complications. They tend to stay in our stroke units or inpatient beds for a lot longer, and they're much more likely to be disabled. There is a chicken and egg relationship here, but certainly they are a predictor of very poor outcomes, death and disability. If you look at the types of complications and the impact it has, they're not small. Increases the risk 2 to 3 times. For a lot of them, recurrent stroke obviously has a big impact, even though numerically it's one of the smaller contributors to, and it's the least modifiable because patients who are under our care with a stroke are already on maximal stroke prevention medications. But the others are patients that we could potentially try to avert getting a complication. One thing I want to highlight that is not in our stroke best practice, but it's something I'm passionate about, is the risk of delirium in our patients. As patients get older, we are taking care of an increasingly geriatric population. And my geriatric colleagues are always very aware of this. This was one of the some literature that was able to pull out the incidence of delirium in stroke patients. And it is not small. It ranges from 1 in 6 to 1 in 2 patients, especially the elderly, are at risk of developing delirium. And when they do get delirium, their risk of dying or being disabled significantly increase, and you see the odds ratio there 4.7. The effect it has on the outcomes of patients are very big, arguably even bigger than developing a urinary tract infection, probably because it's concurrent. And they also stay longer, so like a lot of other medical complications. So this is a picture of my daughter figure skating, and the reason I brought this picture because I'm finding that in this stage of my life, I spend more and more time on the bench accompanying my daughters in figure skating and hockey competitions, warming the bench, and I'm always in awe of how good they are at ice skating. Like when I reflect back on when I was with them when they started skating, I spent about as much time with them learning how to ice skate, but they are just miles and miles ahead of me, way better than I ever could be. Despite all my time on the ice, I still look like a lame duck. Whereas they've just continued to evolve and gotten better. And I think I brought that point up because I think I want to introduce the concept that stroke recovery is an evolving process and is time dependent. The reason why I bring this concept up is that these medical complications that we talked about up there that have a huge effect on mortality and morbidity affect us in the acute stage. But I believe that the implications on the potential for recovery for patients and on long-term outcomes are actually persistent. And those two are most vulnerable to this impact on their potential for recovery are the elderly, the multimorbid, also those who are most frail. This is a paper that I often flash out is instructive of the hypothesis. It was Peter Langhorne, a geriatrician, a stroke doctor in the UK, in Scotland, in Glasgow, and he talks about this curve of recovery. And most of you are familiar, if you take care of a lot of stroke patients, that the greatest bang for your buck or the biggest change in your patient's recovery is in a few days and weeks after their stroke. As time progresses, their recovery starts to plateau out and flatten out. By 6 months, the improvement is minimal. They will have some gap, but their potential for recovery is greatest in the beginning, just as our children's ability to learn is greatest when they're young. When we're old, like as adults, we don't learn how to skate as well. We don't, and likewise in stroke recovery, further down the line, we don't learn to regain our function as easily as the young, as earlier on during our stage of recovery. So when you have medical complications, one of the observations that we've had, though difficult to prove in a randomized control trial, obviously, is that it actually blunts, not just blunts our stroke recovery curve, these complications actually shift the curve to the right and affect our long-term prognosis. And I encourage people to read this Lancet paper that was very interesting in our theories of stroke recovery. So I think the point I want to make about stroke mortality and morbidity is stroke mortality is improving. We're doing a better job overall for patients, but our patients are changing. They are going to require more from us. They are older, more frail, increasingly multimorbid. They're getting more and more medical complications that we have to deal with because of all that. And we need to be on the ball on our game, managing these medical complications and ideally preventing them, because I believe that it has a long-term impact on the trajectory of stroke recovery and the potential for recovery in our patients who are learning how to live their lives again. Any questions at this stage? I will move on to the medical complications. If you have questions about the concept of stroke recovery and impact of medical complications, please come back to it. So when we talk about an approach to medical complications, prevention is always the best treatment, just as prevention of strokes. Much better to avoid the car crash than trying to fix the car once it's broken. And the same goes for these medical complications. We need a holistic, multidisciplinary and coordinated approach to managing it. And stroke unique care personifies a lot of the work in helping our patients recover. You don't just have staff with specialist interests managing these patients, but we take a global approach on our patients, treating their body, not just their body, but also their mind, saying the right things as much as prescribing the right medications, encouraging them when they need to be encouraged, setting goals and strategies to help them cope with what they've lost, and giving them the tools to regain that function back again. It's a complex package of care, not one that's straightforward, and it has to be tailored to individual patients, even if they all have the diagnosis of strokes. When you look at this, this is all not just something, a castle built on sand. When we look at Cochrane reviews going back over 10 years ago, this Cochrane review actually gave us some hard numbers as to how this holistic approach to stroke care actually saves lives. The number needed to treat, treatment effect was about 1 in 20. So just having a stroke unit with 20 patients, you save lives by sequestering all stroke patients in there. There is also a significant impact, not just in saving lives, but even greater impact on reducing disability. What is this magical formula? The Canadian Stroke Best Practice defines some of them. Some of it is a geographically defined unit, having advanced training, seeing people, importantly, meeting regularly as you talk about your patients from different approaches, not just from their medical issues, but also how they're getting on and how they're recovering, setting goals, giving them tools to support them, mental tools to support them through their recovery, teaching them. Stroke recovery is very much about learning. It's not a gym where you just move your arms and legs. It's a lot like a classroom where you're learning how, you're teaching a brain that was damaged how to gain back function that was lost before. A lot of what you see here in all these components of stroke best practice, they can be summarized in this slide. That essentially, if you see stroke patients more, we're just better at it. And this is a paper in 2007 looking at stroke units that showed that volumes matter, which is why we try to sequester all our stroke patients into a specific area so that the people who take care of these patients do it all the time and they become very good at it. There's no one individual factor that helps these patients. It's a combination of factors. So prevention is the best mode of, is the best way to deal with medical complications. But if they still get medical complications, and they do, a large part of this is associated with the effect that stroke has on function and dependency. The measures to prevent strokes, most of you are familiar with, standardized swelling assessments, positioning, urethral catheters. A lot of this is not medication related. Near the end, you see routine DVT prophylaxis. That is important to prevent PEs and DVTs, and also bowel protocols, which we do prescribe, being aware that constipation is a big driver for urinary tract infections and diverticulitis. A paper I wrote a long time ago listed all the medical complications, and if you summarize, a lot of this is related to dependency. Interventions that we do that have the huge impact: early mobilization on the left, you see right at the bottom, anticoagulant therapy, all have big impacts. Early admission to stroke unit has a big impact too, statistically significant impact. And in this study, they looked essentially as about 5 days, ideally. Sooner the better, but up to 5 days. Now, despite all these measures we take to prevent these medical complications, the common ones that we see, focusing on them, is things like pneumonia. So first, most common cause of fever in the first 5 days. Prevention is the best cause of treatment. Identifying those at risk. Most of them are pretty obvious, especially brainstem is involved, bilateral involvement. People who, as you assess them, have speech impairment or have dysarthria, those patients are at greatest risk just by looking at them. Be aware that aspiration pneumonia is different from pneumonitis. Pneumonitis is usually self-limited. Aspiration pneumonia, by definition, requires clinical signs of consolidation or radiological signs of consolidation. Having said that, though, being aware of our concerns about the impact of these complications are on long-term recovery of patients, we are generally more cautious and very cognizant of identifying patients at risk, as I listed above here, and treating them very quickly. Pre-test probability of aspiration pneumonia in a stroke patient with fever. First 3 to 5 days, I often think of aspiration first. Much later down the line, after their first week, I start thinking of other things like UTIs. How do we prevent dysphagia pneumonia, apart from identifying patients at high risk? Basically trying to get a dysphagia, swallowing dysphagia screen. It's in our order sets, but there's a good reason. The sooner patients are assessed for dysphagia, the better the outcomes, as you see on the table on the left. Having a speech and language pathologist assess your patients has a big impact on reducing the risk of strokes as well. And most stroke units have, as a matter of course, in our order sets, both these measures. Where do we get our data for dysphagia and Dopphoff insertions? It was a series of British-based trials. It was staged, trial 1, 2, and 3, but it answered a few questions. And trial 1 essentially was testing the benefit of oral nutritional supplementations in patients. If we talk about being stroke recovery like a classroom, obviously nutrition must play a big part. Across the board for all stroke patients, it looked like supplementing nutritional components to all patients doesn't really change, didn't demonstrate statistically significant benefit, but in possibly based on the trends that you see up there in death and disability, there may be some benefit in people at greatest risk. And in my practice, I look at people who are alcoholics, frail, tea and toast diet, where I'm more likely to supplement them. It's not always Dopphoff feeding, but I would supplement them in this study. I would supplement them with vitamins or other nutritional supplements. Dopphoff and NG feeds can be considered, but otherwise just meal supplements might be considered. I don't use them across the board though, based on the food one trial. The food 2 trial looked at early or late NG tubes, and essentially, again, there was no statistical significant difference. However, there was a trend towards mortality benefit if you started it early. The wrinkle here, the rub here, was that there was an increase in disability. So most of us would accept that it looks like putting NG feeds can be considered early, but before we put them in, we should consider the patient's goals of care. This is heavily influenced partly by their stroke, but more often by the patient's pre-morbid state before they came in. So if someone was severely disabled already and happened to have a stroke on top of that, it will be important to revisit goals of care in these patients before we put NG feeds, but accepting that these patients will often be in a worse state of disability than when they started out. Rushing in to put a PEG tube, the Food 3 trial told us that actually it was a borderline increase in death and poor outcome. So by and large, PEG tubes are not necessarily superior to NG tubes or Dopphoffs, and you can wait. NG tubes probably good enough for most of our patients. Most patients, 70-80% of them who are dysphagic, often recover swallowing anyway and don't need PEG tubes. So we can wait. And I think this usually means that we wait for about a week or 2, often 2 weeks before we put a PEG tube in patients. The patients we might put them earlier are the patients at greatest risk, those with dysphagia with a brainstem stroke. UTIs, another major driver for poor outcomes, a lot of reasons why they get it. as I said earlier on, is a major medical complication with poor outcomes in patients. And because of what we talked about stroke recovery on our stroke unit, I am generally an advocate for early and aggressive treatment for patients with symptomatic UTI. I put symptomatic in italics because with patients who have strokes, it's not always clear whether they are truly symptomatic. Patients who are dysphasic, aphasic, they don't always report dysuria. It's not easy to see whether they have symptoms. So I think generally, while we are careful of our antimicrobial governance, we are conscious that these are patients who are dependent with brain injury. And if they do have a urinary tract infection and there are barriers to their recovery, they're slow to recover, we do tend to treat them for their UTIs more aggressively than we would in the general medical population. If infections are such a big deal, why don't we just treat everyone with antibiotics? And this is a question that's been tested to exhaustion. I won't spend too much time on this, but the PASS and stroke INF study all looked at prophylactic antibiotics early on during stroke. There were only 2 of maybe 8 studies that have looked at it. And I think that idea has been beaten down pretty conclusively that there's no role for prophylactic antibiotics. As much as infections can affect outcomes, just giving the whole population prophylactic antibiotics, if it's such a bad thing, hasn't actually come out in the wash as improving outcomes. So post-stroke infection complications associate poor outcomes. Sooner you screen for dysphagia, the better. Having experts in swallowing, speech and language pathologists assess them, improves outcomes. Infections are bad, but prophylactic antibiotics don't improve it. We just need to be more cognizant at preventing them and then being aware of them when we need to treat them. PEG tubes, generally, nutritional supplementation are recommended across the board, but be aware of those patients at highest risk because of the Food One trial. Early Dopphoff may have some benefit as long as the patient's goals of care are in line. And we don't have to rush with PEG tubes based on the Food Tree trial because it doesn't necessarily improve outcome. A lot of our patients who come in with strokes also have poor glycemic control. So diabetes is a big deal. As I said, diabetes and hypertension increases the risk of strokes almost as much as AFib. Diabetes itself is associated with poor outcomes across the board. It also increases the risk of AFib, which causes strokes. I mentioned earlier on the risk of strokes in patients with diabetes and hypertension is almost as much, if not more, than patients with AFib, which is a major risk factor. If diabetes is so bad for strokes and associated poor outcomes, should we use intensive glucose control? Early in my training, 10, 15 years ago, I found ourselves using insulin a lot and insulin sliding scales. By and large, most of us nowadays would use an insulin sliding scale just early on in the admission, but we will not generally be very aggressive with glycemic control. We would target 11, but we would usually stop once we hit that level. Again, there's been a series of trials. The most significant was the British GIST trial that you see over here, the second trial. And all the studies have effectively shown that intensive glycemic control doesn't really improve outcomes. And this is consistent with in acute coronary syndrome and in acute critical illness. So while it is associated with bad outcomes, aggressive treatment doesn't improve those bad outcomes. In fact, in the UK GIST study, in the discussion, there was an observation of harm given that the risk of these severely disabled patients with hypoglycemic episodes, potentially exacerbating the brain injury. So while we would target 11 and not be too aggressive, there has been major changes in management of diabetes care in stroke patients. So while I might start a scale on these patients, we do start oral hypoglycemic agents quite enthusiastically. Metformin is often used, especially if the renal function is good, because of the modest cardiovascular benefit based on the UK PDS study that you see there. Insulin doesn't actually change, doesn't have good demonstrable cardiovascular outcome benefits. It does save the eyes and kidneys, but doesn't actually reduce strokes in patients who've had strokes. But metformin, the oral hypoglycemic agents, have demonstrated that UK PDS for metformin, modest reduction with the SGLT2 antagonists and pagliflozin. The one that's really had all the headlines is obviously the GLP-1 agonist. Liraglutide was the first in leader, but semaglutide is the one that's really taken the market by storm. And a landmark study for that was the SELECT trial. major reduction in cardiovascular mortality, multimodal effect, not just on controlling sugars, but reducing weight, managing hypertension, anti-inflammatory, maybe some neuroprotective component to it. We're going to see more of it in diabetes care, especially in patients who've had strokes. And just as a historical footnote, because now with the GLP-1s being so powerful, pioglitazone used to be an agent that some of us would consider because of its benefit on reduction of stroke, more modest than the other two agents. But now with with the GLP-1 agonists like semaglutide, Ozempic being so powerful, I think PPAR agonists have kind of faded, and I don't think we'll see it being used very much. It was never very popular because of the risk of heart failure and liver toxicity. But yeah, watch this space. Increasingly, we're looking for reasons to give people semaglutide or the GLP-1 agonists because of the significant cardiovascular risk reduction in diabetics, particularly if they've had a cardiovascular outcome event at high risk. And this trumps a lot of our drive, especially in type 2s, for the use of insulin if you can control them with these cardiovascular modifying agents. Venous thromboembolism prophylaxis, I think it's entrenched in a lot of practice, but again, giving you the background, CLOTS 1 and 2, I kind of glossed over. They were essentially testing the use of knee-high and thigh-high compression stockings, and essentially, while we might still use it for prevention of DVTs in medical patients, in stroke patients, this British-based series of trials were pretty conclusive in showing that compression stockings, just the normal compression stockings, associated with worse outcomes because they develop ulcers, which is a major problem with infections. The one that is of note is the third series in the CLOTS trial where intermittent pneumatic stockings, this was a landmark study that demonstrated intermittent pneumatic stockings significantly reduced the risk of DVTs and pulmonary emboli, improved cardiovascular outcomes, including death. This was useful because it gave us an alternative to just using low molecular weight heparin, which is used across the board in all medical patients. Now, in stroke patients, while we can use it in the majority of patients, we can't use it across the board in patients with intracerebral hemorrhages or patients who have hemorrhagic transformation. This is a reference to our stroke best practice recommendations. It should be used acutely in all ischemic strokes. You can actually use it in intracerebral hemorrhages, but in our guidelines, you need to wait at least 48 hours, have serial repeat imaging to ensure there's no worsening of the hemorrhage, and then you can transition them. Until you do, you would use intermittent pneumatic stockings. We call them moon boots in our hospital, but you must have a similar name for it in your hospital. Why would you not give fragment prophylaxis to an ischemic stroke? This is the reason why. About half of patients after stroke sometimes will get hemorrhagic transformation. Thankfully, most of the time, the hemorrhagic transformation on your brain scans look a lot like the first two here, the HI1 and 2. Now, these patients are often asymptomatic. They're just picked up incidentally. You see the report in your CT scans. They say a small amount of petechial hemorrhage, no mass effect. The reason why these HI1 and 2 doesn't change our antithrombotic choice is that it's mostly just a bit of bruising or blood leakage into an area of already infarcted brain without mass effect. There's no new brain damage. It's just blood in an area that's already infarcted. So patients aren't that badly affected. And we want obviously to start them in antithrombotics to prevent PEs, but also aspirin to prevent another stroke. When the types of hemorrhagic transformation that we actually hold aspirin and prophylactic anti-thrombotics will be those that look like PH1 or 2. And typically when you see mass effect, when you have mass effect, you have enough blood in there to cause swelling to damage healthy brain tissue. And you don't want to make that any worse. I've just given this for example. Sometimes it can be difficult to decide the toss, but in PH1, you see that there is mass effect because as you see the posterior horn of the ventricle in PH1 there is effaced and you can't see it anymore. So obviously there's enough mass effect to damage the brain, and potentially these patients will be symptomatic. PH2 on the left, on the right is pretty obvious that if any of us saw that, most of us would go, gosh, we need to stop because there's blood everywhere. You can see squashing on the ventricle on the right-hand side, and that's obviously causing new damage to the brain. So in these patients, typically we wait 2 to 3 days, like our ICH patients, and then reassess if they got any worse. And if they're no worse, we will then start them maybe in a stage fashion with aspirin or we'll start them with prophylactic heparin, either one of the two, before escalating. So pH 1 and 2. Now this is difficult, but essentially when you ask, but this is a commonly asked questions, how long do you hold these drugs? Who should you hold it on for? It's based on this ECAS-3 criteria. One of the original thrombolysis studies back in 1995. Not in our guidelines, and hence it's in italics, but delirium prevention, I think it's important in our elderly, frail, increasingly elderly stroke patients. I think we should identify patients at greatest risk, the elderly, those with underlying cognitive impairment. You should consider non-pharmacological measures to prevent it as much as possible. Be aware of the use of regular acetaminophen, even if they don't have overt pain. There's a lot of geriatric literature that it seems to help in patients, particularly surgical, but also medical in patients, in reducing the risk of developing delirium. Be aware that a lot of our stroke patients who have had acute brain injury, been in the hospital a long time, and they're prone to it. Be aware of sleep dysregulation. And we do have some guidelines in our hospital derived by our geriatricians to help us with melatonin and use of these antidepressants. The trazodone is widely used. I use it a lot at low doses. It's a SARI antidepressant, and it's quite effective. At low doses, it doesn't seem to have a hangover effect, and it does help with sleep dysregulation and reduce the risk of sundowning, which can be a major barrier to recovery. Any questions before I move into acute blood pressure management? So this was the last one, was acute blood pressure management. And the reason I had added this into my slide is I had a chat with some of my colleagues at Dravinsky Hospitalist there, and most of us are quite nervous about managing hemorrhagic strokes. And I think blood pressure, well, technically speaking, not a medical complication. You could argue that it is a result of the stroke and hence a complication, because it's chicken and egg. High blood pressure causes strokes, but yes, the strokes themselves can cause high blood pressure acutely. It is a point of contention, less for ischemic strokes, but it's one that we are very concerned about, particularly for hemorrhagic strokes. For ischemic strokes, high blood pressure is common because it increases risk of cerebral edema. It doesn't tend to necessarily increase the risk of hemorrhagic transformation. Most of that is associated with size of infarct. So the bigger the strokes, the greater the risk of hemorrhagic transformation. Because of that, typically when people have had an ischemic stroke, we don't aggressively lower the blood pressure. There's this notion, this term we use of permissive hypertension, where we let patients run high. If you're giving TNK, we target less than 180. If you're not given TNK or EVT, we actually let them run up to 210, 220 as a threshold for permissive hypertension. And the idea for this is that when patients have had damage to the brain, their systemic circulation is the predominant driver for cerebral perfusion pressure. They've had damage to the blood-brain barrier. In order to get blood, the systemic pressure needs to be high to get blood into the brain that's been deprived because of a clot blocking the blood vessel. That's completely turned around in hemorrhagic strokes. When people have blood in the brain, the thought is that the blood vessel is leaking. High blood pressure is a major determinant of the hematoma getting bigger as blood leaks into the area. So in hemorrhagic strokes, this is one of the, while we have a lot less therapeutic interventions for hemorrhagic strokes, blood pressure control is probably the cornerstone at the acute stage for hemorrhagic strokes. Chicken and egg. Maybe the high blood pressure caused the hemorrhage, but certainly when they have hemorrhage and a raised ICP, it is a complication. They do get very high blood pressure. And there's a worry that, particularly for hemorrhagic strokes, if blood pressure is run high, there's a very big risk that their bleed will get bigger and patients will do badly. And hemorrhagic strokes often have us very nervous because we feel sometimes helpless as they deteriorate. They carry the greatest risk of mortality, most likely to die, and also arguably have the worst outcomes, most likely to have long-term disability compared to ischemic strokes. And often, because there are limited therapeutic options initially, a lot of hospitalists manage them before they're transferred to the stroke unit. And those who in stroke units, we watch them and try to manage them as well, and they can be challenging. Apart from high blood pressure, low blood pressure is also bad. So you need it like Goldilocks, somewhere in the middle. This is less of an issue. Typically, people with strokes who have low blood pressure, there's something else going on. A lot of the medical wards, when they ring me for code strokes as inpatients, they get strokes because they have low blood pressure. and there's something else going on. These patients generally don't respond as well to our acute stroke treatments. The underlying core of the treatment is to treat the underlying source of it. If they have a blockage in the arteries, we will open up the blockage with EVT, or maybe even give them thrombolysis. But by and large, the outcomes are not as good because they have something else that caused the stroke. If they have low blood pressure, I will often give them fluid boluses to try to expand it. Very rarely do we ever give them vasopressors. The data in vasopressor use in acute stroke is very poor. It was actually associated with worse outcomes. So in randomized controlled trials, its use in a population of stroke patients is not recommended. If it's ever used, it's used for very specific patients, usually as an adjunct until they get reperfusion treatment, alteplase or TNK, or more likely AVT. And these are the reasons why people have high blood pressure, just as a series of physiological measures that occur. So as I said earlier on, blood pressure lowering in acute stroke is rarely indicated, except in the context of TPA or EVT, or if they have a hemorrhage. The choice of agent is typically practical. Most of these patients are in acute stroke context, so they can't eat and drink. You've made them NPO. And the other issue is you want it to work quickly. If they have an intracerebral hemorrhage, you don't want to give them amlodipine, because amlodipine has such a slow time of onset. It takes about 12 up to 12 hours to start working. So that's kind of being late to the party. You want it to work when you give the drug within an hour or two. So you want drugs that work very quickly. Sometimes that means you have to give them IV drugs. And because you want to work quickly, you also want it to be titratable, because you're targeting often a specific target. So these practical considerations do matter. The typical strategies we have is either you continue on their blood pressure medicines, no, because they are dysphagic, so we don't do it. We actually have a study that demonstrated that if people are hypertensive and you were planning on lowering the blood pressure, just giving them their regular blood pressure medicine doesn't work. Interestingly, there was an increased risk of aspiration pneumonia. So it looks like it was a dysphagia issue. Should we just lower blood pressure across the board aggressively? This was particularly a thought for patients who had TPA or EVT, and a recent study that was done, prior studies with TPA, and a more recent study reported in World Stroke a week ago showed that aggressive BP controlling, even in EVT patients, didn't demonstrate any benefit, and if anything, there was a trend towards harm. So we do need higher blood pressures when patients have had an ischemic stroke, whether you receive TPA or EVT. If it's a hemorrhage, for whatever reason you want to control their blood pressure aggressively, these are the typical agents we use. Labetalol is the most commonly used in our center. It can be given oral or IV, more often IV in acute stroke. Labetalol is not a true beta blocker. It's not like metoprolol. It's a mixed alpha and beta antagonist. So it is a negative inotrope and chronotrope, but for those of us who like pharmacology, it's also an arterial vasodilator and decreases peripheral vascular resistance. By decreasing peripheral vascular resistance, in spite of its action on the heart, it's actually probably cardiac output neutral. So it doesn't affect cardiac output. And the thought is that if cardiac output is neutral and the brain is being dependent on the systemic circulation, it's unlikely to reduce cerebral perfusion. So the labetalol is nice to use. It's used effectively early on in stroke because there's a big sympathetic drive that's often driving it early on. And I find that I only need to give a bolus or two, and then their blood pressures are better. By the time it wears off in a couple of hours, their blood pressure has settled down. In the odd occasion that it doesn't, we start a labetalol infusion that gets to the root of the problem, doesn't affect cardiac output, and it is easily titratable. So labetalol is used a lot. The only downside for labetalol is that it causes bradycardia. We have an answer. If they are bradycardic, we tend to use IV hydralazine. Hydralazine can be used oral as well, quite quick acting, but IV hydralazine can be given because if they're NPO, IV hydralazine we're not entirely clear how it works, but it's predominantly an arterial vasodilator. It probably acts on nitrate breakdown, so it causes your endogenous nitrates to go up. May explain why when you use it with nitrate patches, it can cause a precipitous drop in blood pressure. But yep, use it in patients who are bradycardic, and in fact, it's a drug that can sometimes cause tachycardia. So just being conscious of that. But it gives you a yin and yang. If you can't use the beta law, hydralazine is not a bad counterpoint to it. Other IV drugs we give is enalaprilat, which is the IV version of enalapril. All ACE inhibitors can be active as in the oral form, but they are prodrugs, which means that when they're broken down into their metabolite, the metabolite is active too. Enalapril is similar. Enalaprilat, which is the IV drug, is just the metabolite of enalapril. Works very quickly, lowers blood pressure. Just be careful in renal impairment. It might affect the kidneys. And in some rare occasions, in people who have bilateral renal artery stenosis, they are very renin dependent on their blood pressure. You can tank their blood pressure a little bit too quickly if you gave them enalaprilat. We don't use very much, but in your center, you might consider nicardipine. There is some data for the use of calcium channel blockers to lower blood pressure. We don't have it available in our site, but we have all these other alternatives which work for most of the scenarios. There are some people who will use diuretics like mannitol, a nitric oxide donor, but they really are quite far down the list. Mannitol really is only used as an adjunct to lower blood pressure and intracerebral hemorrhage to neurosurgery. So you see it being used a lot in neurosurgery. So intracerebral hemorrhage is the ones we worry the most, that we have to control the blood pressure and manage them. The blood pressure, the recommendations, as I show verbatim here, is kind of vague. They say you can lower it if you want to, so it may be reasonable. It doesn't say you have to lower it, and it's mostly because a bunch of trials in setting intensive blood pressure control, even in hemorrhage, has really failed to show significant benefit or clear benefit. In practice, a lot of us would identify patients at highest risk of hematoma expansion, and we would target less than 140. So we want to select people at greatest risk of getting worse, because there's a good chance that they may get better. Not because we know for sure based on randomized trials, but selecting a population that might benefit, just so that we are doing something to prevent them from getting worse. And the predictors of people that might benefit are listed up here. Early onset, you see them within 6 hours. They have high blood pressure, and they are on anticoagulants. Heaven forbid you gave them TNK, or your CT scans show that they have markers of hematoma expansion. This paper in 2007 has all those features of hematoma expansion. So size, the bigger the stroke, the bigger the hematoma, the greater the risk of expansion. Spot sign, those of you unfamiliar, this is what happens when you do we recommend that you do a CT, CTA in all hemorrhagic stroke patients. When you give the contrast to do the CTA, if you see contrast actually floating in to the hematoma, it suggests to you that there is active blood going into ongoing bleeding into the hematoma. So the pipe's still leaking. Here in slide C, you can see it getting bigger. All that is in a multi-phase CTA. You just take another image of the brain after the contrast has gone through, and you see that it's ongoing blood leakage, kind of a dynamic study showing blood seeping into the hematoma. Other predictors that you see is blood in the ventricles. You see in D there. And if it looks like there's a cloud with lots of little spots here and there, heterogeneous implies that the blood has been bleeding, stopping, bleeding, stopping, bleeding, stopping. That kind of behavior of a hematoma makes you worried that they'll bleed and stop, continue to bleed and stop again. Now, these radiological markers, along with the clinical markers I showed down there, those may be reasons to target a lower blood pressure with the drugs that we discussed. We're always nervous. All hemorrhages should be discussed in neurosurgery. Some people really need to see neurosurgery more than others. Those who have reduced LOC, those who have intraventricular extension because they might need an EVD, those with posterior circulation hemorrhage, the cerebellar hemorrhages, you really need to get neurosurgery involved, because the posterior fossa a lot smaller. You have a lot less leeway and space for the hematoma to expand. More superficial bleeds obviously may benefit more as well. If patients are being sent for neurosurgery or waiting to go to neurosurgery, you can consider these hyperosmotic agents as a temporizing measure. So we talked about mannitol as a diuretic dish to reduce ICP, or hypertonic saline. And these are in some of our best practice recommendations. This is going to be a tough one, because I know that a lot of people are very nervous about managing ICH. It's very easy to feel helpless managing these patients, because you can only lower blood pressure, and there's no guarantee that the patients will benefit from lowering blood pressure, but we do it anyway, because there's a chance that it might help. So I think I've covered most of the medical complications post-stroke. I covered the most common ones. There are about 20 or 30 medical complications. I hope my attempt at covering acute blood pressure management was helpful, even though it's not technically a medical complication, though I think I made a strong argument for it. Any questions in the last 15 minutes of this talk? Thank you for your kind attention.
Thank you, Dr. Ung. Yeah, so please feel free to write questions in the chat, or you're welcome also to unmute if you'd like. You can raise your hand or unmute and ask. Okay, so we have a question here. Can you comment on any studies that might have been done on UTI post-stroke for patients on SGLT2 inhibitors? Interesting paradox.
So that's a very good question. Maybe I can frame it. So SGLT2 inhibitors have about a modest effect on cardiovascular outcomes, about 15% relative risk reduction. So they're modest. But you're right, I'm always a little bit cautious using it in acute stroke units. If my patient is not eating and drinking, it's not even a UTI. I worry about euglycemic DKA. And that can be a medical emergency. Very easy to miss, even if you're aware of that complication, because your patients don't come with high sugars by definition. They actually have normal sugars. The only first sign of a complication is they become tachypnic. And every time you see a tachypnic patient in a stroke unit, you think aspiration pneumonia. It's only when you do a VBG, you find them grossly acidotic. So I think that's a good point, Frank, that you brought up. So I use them when patients are better, they're eating and drinking well, so that at least they're well hydrated. And then I would consider them later in their stay or in the rehab component of it. Not my first go-to drug. It's an option because I'm trying to keep these guys off insulin if I can, because of my bias towards cardiovascular risk reduction. But I think it's like everything in stroke, timing is everything. Metformin is my first drug I introduced, and empagliflozin when they're eating and drinking very well. And then I'm just itching and using an excuse to give them a GLP-1 agonist after that. I hope that answers your question a bit, Frank. Yeah, the oral drugs are nice to use. I often, an interesting footnote in these drugs, metformin and SGLT2, patients sometimes, just to encourage compliance, I often tell them that these drugs have natural sources. Metformin is a French lilac extract from French lilac trees, and we have a few of these trees in Ontario. That seems to reassure people it's not as mysterious. The SGLT2 inhibitors, the empagliflozins, paraphrasing them, is they're called fluoresceins. They belong to a class of drugs that actually derive from apple trees. And so again, when I tell people I'm giving you some apple tree extract, they like taking it, and it reassures them when I see them in stroke prevention clinics. Removing the mystery of the drug seems to help with compliance as well. When I try to sell them semaglutide or Ozempic and I tell them it's saliva of a lizard, I'm not sure if it convinces them to take it. But when I tell them Elon Musk and Kim Kardashian takes it for weight loss, then they maybe that sways it the other way.
So Frank wrote a comment. Thanks. Agree with your caution and appreciate your insight.
I have a question. Sorry. Could you touch a little bit more maybe on the DVT prophylaxis in post-hemorrhagic strokes? I always, of course, there's lots of variability. And so do you get a CT, CTA on everybody? And in terms of timeline and in terms of what you typically time frame to start DVT prophylaxis?
It's a good question, Amanda. It's one I'm very nervous with. It often feels like we need to have courage to start to write heparin or fragment in someone that has blood in the brain. It's a bit like CVST, the cerebral venous sinus thrombosis. The guidelines, they do help. So typically, in response to your first question, the guidelines do recommend CT hits and CT angiograms as much as possible. The CT angiogram is twofold, to look for people at for a source of bleeding, like an aneurysm, but also because you want to identify whether they are at risk of hematoma expansion with that spot sign that I mentioned earlier on. So if you have blood still leaking in the hematoma, it's obviously bad. So I think we should do CT hits and CTAs. Those guys, you aggressively control the blood pressure. I think most of us, very few, I don't know any of my colleagues that will not repeat a CAT scan the day after, because we want to know whether they truly have expanded. So usually there's always serial imaging. So 24 or 48 hours later on, there'll be another repeat CAT scan. And if there's no expansion of the hematoma, no clinical deterioration of the patient, the guidelines again do say that it is reasonable to start DVT prophylaxis after 48 hours. So, and I use that for the hemorrhagic transformations too. So the ischemic strokes that transform, and they have pH 1 or 2, where we go, whoops, all the brakes on prophylaxis. I also wait similarly 2 days before I re-image them and then decide whether to start them on prophylaxis. So I like it because it's consistent, knowing that you assume that seeing blood in the brain is not good. Does that answer your question, Amanda?
Yes, thank you so much.
48 hours. I think it's not a clear evidence-based medicine. I think it's an expert opinion one. A bit like this slide I have here, timing of anticoagulation. These are not evidence-based trials. I know we look to evidence to give us a foundation, but a lot of these things are difficult to do a trial in. Most of it is based on expert opinion and consensus. So 48 hours is the cutoff for that. I hope this is helpful. This is not really the scope of my talk, but it's a common question I get from non-stroke specialists on how to timing of anticoagulation, because AFib is so common. I often take a snapshot of this on my phone. It's from ESC. It is actually fairly consistent with our Canadian stroke best practice recommendations. They use the 3, 6, and 12 days delays, but there's actually a nice table here, so it's easy to take a picture and store it as a favorite photo. And then when you have patients and you're trying to decide anticoagulation, I find this quite a useful guide for me. So I'm any opportunity or excuse, I always flash this for people to keep. I think there's a PDF for distribution.
Yes, so I can let everyone know that by tomorrow, the recording of the presentation and a link to the slides will be available on the website. Rhonda.
I was just going to do a teaser to that is also part 3 in our Hospitalist series on November the 21st. At 12 to 1, we're also doing an hour-long presentation on the navigating the thrombotics in stroke management. So great teaser to introduce it, Dr. Ung. We'll hear from Dr. Sharasta on the 21st. So more to come.
I put some other slides attached in the PDF. This is again for people who are managing and discharging patients with hypertension. It's our biggest modifiable risk factor outside of AFib. And there are some guidelines on how to measure blood pressure. It's very individualized per doctor and by patient. But this is generally my approach to it. I tend to prefer longer acting drugs. I'm heavily influenced because of my training in England and my time at Oxford by how they manage hypertension. And there's Peter Rothwell, who's based there, did a lot of work on the Oxford database, strongly recommending the use of amlodipine, the long-acting antihypertensives like indapamide, the thiazide-like diuretics, not necessarily hydrochlorothiazide, but favoring indapamide, clothalidone, and also amlodipine for preventing strokes. There's a big argument about it being longer-acting and being better for stroke prevention. Again, this is in the slides. You don't have to, I didn't talk about this. I thought it was helpful for people to look up if they were interested. I manage a neurovascular clinic, and I'm always aware that my patients, only half my patients take all the meds we give them. So I'm always very big on compliance and minimizing side effects, whether they tell me they have them or not. But I'm always very open. I'm always full of anecdotes to communicate where drugs are from, to minimize this mystery of drugs. I suspect most of us, fear drives a lot of the ignorance and compliance. We always fear the monster in the cupboard. But if you open the doors to the cupboard and you can see right through and you know what you're taking, people don't fear it. And if they don't fear it, they're more likely to take it. So I encourage us to have that approach when you're managing some of these things.
So we have another hand up. Frank, go ahead.
Yeah, sorry, one more question. And I may have misheard you, but when you're talking about hypertension, time of presentation of stroke, you said that you stopped all their home, that they did better off their home medicine. You just kind of talk a little bit about that, because that's would be quite a change, I think, for most of us, which I welcome any change. I'm not, I just want to just hear the evidence that would support that, and and when you would reinstitute, or what you would choose to reinstitute, I guess, as before they went home.
Let's actually go with Frank. Thank you for highlighting that. I think that I need to give context to that. So that was a study called the STOP study. It was actually done in a place where, also done in the UK. And one of the thoughts was that if patients have had a stroke because they were hypertensive, why don't we just continue with their blood pressure medications throughout their stay in hospital? This was actually only the acute phase. So this is when they've just had a stroke, you see them for the first 2-3 days. Stop. The idea of permissive hypertension, I think, is universally used. This was one of the feeder studies that led to the recommendation: when they've had a stroke, first 42, 48, 72 hours, hold all antihypertensives, let them run high. So it's just stopping it. Before we had this consensus about allowing permissive hypertension, there was some thought that because hypertension is due to blood pressure, rather than them swinging the blood pressure when you suddenly stop the meds, there was a thought that maybe we just continue on the blood pressure medications, and that might be beneficial. So actually, you're right, Frank. We hold their medications first 3 days, and then we gradually reintroduce their medications. Does that provide context?
Yeah, no, I love it. Like, honestly, I kind of prefer less rather than more, so I'm kind of a big fan of that. It's always one of my goals. But so in terms of reintroduction, then would you? I mean, obviously everything depends on renal function, et cetera, et cetera. But in terms of favored class, like, would you start first with an ACE slash ARB? Would you? You said that interestingly, amlodipine again takes a long time to get blood pressure. It takes longer to get blood pressure under control. Maybe just talk a little bit about exactly how you might reintroduce and what would be your favorite classes.
For sure. I'll start with evidence. So the PROGRESS study was the primary secondary prevention landmark study for us. PROGRESS used perindopril versus perindopril indapamide versus standard treatment, 3 arms. And the study that actually benefited the use of perindopril was actually the perindopril indapamide arm, where there was a reduction in cardiovascular outcomes. Perindopril by itself didn't really have that effect. It's not because it was a dud with ACE inhibitors. It was mostly because it was not as effective for lowering blood pressure. So there was like a 4 millimeter drop of blood pressure. When you actually use the combination of perindopril and indapamide, and you increase blood pressure more, you saw the signal, and statistically significant signal of reduction in cardiovascular outcomes. So I typically, my approach when I have someone who's hypertensive, I favor long-acting drugs because of what I said earlier on. The short-acting drugs don't seem to have that stroke risk reduction signal. Long-acting drugs are perindopril is often, ACE inhibitors are often used as long as you use them appropriately. Perindopril is quick onset. It works within an hour or two, like all ACEs. It's derived from snake venom after all. And no, snakes are impatient. They don't wait for the venom to work the next day. When they bite their rats to eat, they want it to work straight away. So ACE inhibitors are derived from snake venom. So they're quick onset, long-acting. In this case, in perindopril's case, I use it in people with diabetes, and I use them in people with coronary artery disease. Evidence of LVH on their echo or their ECGs. So that's my go-to, my compelling indication. But if I have no other compelling indication, and an older patient, maybe an Afro-Caribbean origin, I will use drugs like amlodipine as my go-to first. Like for the SGLT2, if they're eating and drinking well, only then do I add a thiazide type diuretic, because I don't want to have to deal with the hyponatremia and the hypokalemia if they're not supplementing the oral intake. So my amlodipine I use because I'm in no rush. I think I want to use it because I'm hoping to establish them on it as their long-term drug, ideally. So I don't want to just swap and change. It is very long-acting and also very slow onset. So for secondary prevention, unless you have compelling indications, I use ACE inhibitors. So I use amlodipine, but a lot of our stroke patients have compelling indications. So perindopril is used quite widely. And the combination of perindopril and indapamide and amlodipine is not uncommon. You can merge them into a combination pill when you see them in your follow-up clinics.
Well, thank you, Dr. Ung. It is 1 o'clock, so knowing that people do need to get back, I want everyone to know again that the recording will be available, and I've just put a link that you can access all of our archived education on the Central South Stroke website. And just to highlight that our next presentation in the stroke series for hospitalists is November 7th. Dr. Salas will be speaking on the management of carotid artery disease, and it's the same Zoom link meeting ID for each of the webinars in this series. So thank you again, Dr. Ung, and for all of the great audience participation, and we will see you soon. Have a great afternoon.
Thanks a lot. Ciao.
Hi, everyone.